Hello, my name is Professor Peter Kaiser. I'm the Cheney Family Endowed Chair in Ophthalmology Research at the Cleveland Clinic Lerner College of Medicine and a professor of ophthalmology at the Case Western Reserve School of Medicine. Today, I'm going to talk about precision in practice, adopting emerging therapies for retinal diseases to reduce the burden of disease. Both DMO and neovascular age-related macular degeneration are leading causes of blindness worldwide. It causes a huge problem in terms of quality of life, especially if these are working aged patients. But in addition, there's the burden of treating these patients. Because most of our treatments last anywhere from 1 month to 3 months, this requires very frequent visits to our clinic. And this can present a logistical challenge because you may need to be driven to that appointment, especially if you have disease in both eyes. So not only do you need to take a day off from work in those DMO patients, but a caregiver may need to drive you to those appointments. This, of course, can lead to productivity issues, out-of-pocket expenses, losing time at work. And finally, there's that burden we really don't see, which is the burden to adhere to these treatments, these frequent disease activity assessments and injections. Well, the first thing to define is really what does it mean to require intensive treatments? We certainly have patients who do very well with our current therapies, and those patients can go even up to 12, even 16 weeks with our current therapies, but that's not the majority of patients. In fact, the majority of patients need relatively frequent injections. And then there's the patients, about 25 to 30%, that require maybe monthly or every 6-week therapy with our current anti-VEGF agents. And these are the patients that we would really like to be able to extend the interval because those are the ones that are showing up at our clinic quite frequently. So really, if we could do something for these intensive patients who require intensive treatments to reduce the treatment frequency, this would really have a big impact on everyone's lives. Fortunately, we have had several approvals to hopefully reduce treatment burden and better treat neovascular age-related macular degeneration and diabetic macular edema. One of the first drugs that was approved was called brolucizumab. And in the brolucizumab studies, they did something very interesting. The control group was aflibercept 2 milligrams dosed every 8 weeks after a loading dose, whereas the brolucizumab arm went either every 8 or 12 weeks, depending on disease activity. The primary outcome was at 1 year, and the non-inferiority margin was met. So in other words, treating patients every 8 weeks with aflibercept 2 milligrams was similar to treating patients with brolucizumab either every 8 or 12 weeks. So that was our first drug to really look at the idea of extending treatment intervals. The second drug that was approved was faricimab, and faricimab was a little different. Unlike all our current anti-VEGF agents, which really work on the VEGF pathway, faricimab blocks both VEGF-A as well as angiopoietin-2. And angiopoietin-2 works on the Tie2 pathway. It's a different pathway than VEGF. And in the Tie2 pathway, the goal is to enhance Tie2 activation, which leads to vascular stability. And you do that by blocking angiopoietin-2. And in its clinical studies, they did a very similar thing as brolucizumab, comparing themselves to every 8 weeks of aflibercept 2 milligram, but they went every 12 or every 16-week intervals. So they went a little bit longer intervals depending on disease activity. And again, the non-inferiority margin was met. So in other words, the visual acuity results were similar at 1 year, but with an extending dosing interval. Next was a delivery system, which was called the port delivery system, which is a surgically implanted device. And into that device, you place a higher dose of a special formulation of ranibizumab, which then slowly diffuses out of the surgically implanted device into the eye. And in its study, they tested against ranibizumab given every month, and with the port delivery system refilled at 6-month intervals. And the non-inferiority margin again was met, indicating that refilling this device every 6 months had similar results as monthly ranibizumab injections. That is not yet approved in the EMA in Europe. It's approved in the United States, but it requires a surgical implantation of the device, which limits its use even in the United States. And finally, aflibercept 8 milligrams was recently approved. Now, aflibercept 8 milligrams is a higher dose of the aflibercept 2 milligrams that we have decades of experience using. So why would you increase the dose? By increasing the dose, you essentially increase the time the drug is in the eye, which increases its durability. And just like the faricimab studies, the aflibercept 8 milligram study tested against aflibercept 2 milligrams dosed every 8 weeks. And the aflibercept 8 milligrams was dosed every 12 to 16 weeks. The non-inferiority margin was met, just like all the other studies, indicating that we could dose this drug every 12 to 16 weeks. Now, the interesting thing about both faricimab and aflibercept 8 milligrams is what happened in the second year of the study. Because in the second year of the study, you could look at extending the intervals even longer. So in the faricimab studies, in particular the diabetic macular edema studies, they used a treat and extend approach that is very commonly used in clinical practice. And the aflibercept 8 milligram studies also used a very similar sort of a treat and extend with the idea that the patient was stable, they could extend the interval even further. And in that second year of both the faricimab studies as well as the 8 milligram aflibercept studies, patients were able to go well beyond a Q16-week interval. In fact, with the aflibercept 8 milligram dose in that second year, they were able to get out almost a quarter of the patients to a Q6-month interval, so 24-week interval. There are some patients who can make very extended intervals, both with faricimab and aflibercept 8 milligrams, but certainly not all the patients can make it. So when we look at the 4 new treatments that we currently have, including 3 anti-VEGF agents and 1 surgically implanted delivery system, all of these different therapies allow us to go for an extended interval of time. The ranibizumab port delivery system was dosed every 6 months in the clinical study, but in reality, you could actually go much longer. The refills, of course, are what are required. And hopefully in the future with things like home OCT, we'll be able to determine when refills may be required. But since it is a surgically implanted device, oftentimes this is not the first choice for many of our patients. Now, brolucizumab is an interesting drug because the clinical study showed extended treatment durability and also very quick drying of the retina. But there was a safety issue in that a certain percentage of patients actually had intraocular inflammation and could develop retinal vasculitis and even retinal occlusive vasculitis. And it's very difficult to predict which patients at baseline may develop that type of complication. And because of that safety, even though it's a very good drug and one that we continue to use to this day, the other 2 drugs, faricimab and aflibercept 8 milligram, have sort of supplanted its use in clinical practice. Now, if we look at the aflibercept 8 milligram photon and pulsar studies, really what you want to look at is the 24-month data as well as the 36-month data. And in that extended duration of the study, what we learned, because treat and extend was used, is that more and more patients were able to go 12, 16, even 24 weeks between treatments. Similarly, in the faricimab studies, so for neovascular macular degeneration, that would be the Tenaya and Lucerne studies, and in those studies, basically what they showed was you were able to go extended intervals in that second year and beyond. Yosemite and Rhine were the studies looking at diabetic macular edema and used treat and extend in the second year. And again, even though in the first year they didn't get many patients to extend the interval, in that second year, they certainly did. And so when I talk to my patients about using either faricimab or aflibercept 8 milligram, I don't really tell them that everybody's going to get 12 or 16-week intervals or longer between their treatments, but I do say that we hope to get a longer durability versus the treatments we've used in the past, including ranibizumab and aflibercept 2 milligram. These real-world studies, you really have to look at them closely because some of them are retrospective studies and some are actually prospective studies. And ideally, the prospective studies are the ones that you would put the most weight into. But in general, the real-world studies have mirrored the clinical trials in that the real-world outcomes with these newer agents have shown us that patients were not responding very well in the past to either ranibizumab, off-label bevacizumab, or aflibercept 2 milligrams. when switched to one of these newer agents did better. And what do I mean by better? Well, some of the real world studies switching to aflibercept 8 milligrams have shown that patients have improvements in their OCT, small improvements in visual acuity, but most importantly, they are having an increased durability. Now, remember, when you switch to, say, aflibercept 2 milligrams to aflibercept 8 milligrams, you don't necessarily expect to see an improvement in vision in a patient who's been treated aggressively. What you expect to hopefully see is an increased durability. So for my patients, there's kind of two use scenarios. One are those patients who are, say, receiving every month injections, and I want to try and increase the duration between treatments. But the second use scenario for aflibercept 8 milligrams are those patients who are actually doing well on aflibercept 2 milligrams, say at 12-week intervals or even 16-week intervals between injections. And these are perfect patients to try to place on 8 milligrams and go even 20 or 24 weeks between injections, like was shown in the extension studies. Now, faricimab has also excellent real-world data in that patients who were receiving frequent injections were changed to faricimab. And in general, in these real-world studies, the visual acuities improved a little bit, and the OCT retinal thickness also improved a little bit. But again, the most important thing about these real-world studies is that you're able to increase the duration between the injections. Now, brolucizumab is a special case in that although the treatment is very good and dries the retina remarkably well, in fact, it's one of the best drying agents we have, the risk and side effects of the intraocular inflammation reduces our use of that drug. And similarly, with the port delivery system, the ranibizumab port delivery system requires a surgical implantation. And in the clinical studies, side effects including erosion around the implant, blebs forming over the implant, and even as bad as endophthalmitis in a small population of patients limits its use in the United States, and it's not yet approved in Europe. We really need to individualize our treatment for the patient that is sitting in front of us. So we want to look at things like what lesion type is it? Is it type 1, type 2, type 3 lesions? So for instance, type 1 lesions in general do very well and doesn't require as frequent of treatment, whereas a type 3 lesion may require very intense of treatment to prevent atrophy from forming. And when we look at patients when they return for follow-up, the things we look at to determine should we increase the duration or decrease the duration between treatments include looking at the OCT as well as the visual acuity. In general, patients who respond very rapidly with a nice reduction in retinal thickness, elimination of intraretinal fluid on the OCT, those patients oftentimes are the ones that are ideal for increasing the treatment duration. Those patients who don't do well, especially if we started with, say, off-label bevacizumab or ranibizumab or even aflibercept 2 milligram, those are the patients who we'd be considering early changing to one of these newer agents. And the reason we want to change early is because the more the fluid persists, the more likelihood of us not being able to gain visual acuity in the long run and produce fibrosis and atrophy in the long run. So really, you want to be quick to switch if you're not having a treatment response early on. And then the final characteristic I look at is how easy is it for the patient to return for follow-up? If your patient or even the caregiver implies these visits are getting difficult, that would be another reason to look to switch to a longer acting agent to hopefully allow them to adhere to the treatment frequency, but still maintain the visual results that we want them to retain. We know that the less injections someone gets over time compared to what they actually needed is the main reason for vision loss in the long run. So matching treatment burden and the number of treatments by increasing durability is something very important to maintain good visual results. When a patient is either doing very well on our current anti-VEGF regimens or the opposite, not doing well and requiring frequent injections, that's when you discuss with them the idea of switching to one of these newer agents. And it's very important in that discussion about switching to these newer agents that you set proper expectations. While many patients were able to go for a very extended duration, many patients could not. And so in general, I speak to patients, I say the goal of switching the medication is to allow us to hopefully have better reduction in fluid while maintaining good visual acuity results. And the next positive benefit of that would be allowing us to increase the treatment duration. In patients who have good durability on current treatments, we also have to be careful about switching agents. So, in general, I like to keep patients on aflibercept and switch them from 2 milligrams to 8 milligrams when they're doing well on 2 milligrams, because in general, those patients will be able to go for extended duration with 8 milligrams. But in general, when I switch patients, that first interval, I like to bring them back at the same interval they were on previously on the previous drug. So if they were on monthly treatment, I'll bring them back in a month. If they were on, say, Q12 or Q16 week interval, I'll bring them back at that same interval because I want to really compare apples to apples versus the old medication before deciding on extending the treatment duration. Well, sustained disease control is defined in my mind as having a good visual acuity result, having good response on the OCT in terms of decreased fluid, decrease fibrosis, and a prevention of atrophy, while at the same time allowing us to do this for the extended period of time that these diseases require. So, for instance, in a patient with neovascular macular degeneration, we may have to treat a patient for a very, very long time. Not so much in DMO. So sustained disease control is a little bit different between the different diseases. You need to bring them back and monitor them and make sure that their visual acuity is staying good, make sure their response on the OCT is staying how you would like it, and adjust either the drug you're using or the treatment interval that you're using, depending on the response to treatment. And finally, it's very important that patients understand their role in this. If you're going in an extended interval and they suddenly notice a decrease in vision, they shouldn't wait till the next time they see you to tell you this. They should be calling your office so you can bring them back for monitoring to see what's going on. Now, in the future, we hopefully will have drugs that may even go longer or allow us to have even more disease control. So there's several polymers that are being looked at using tyrosine kinase inhibitors, and these treatments may be able to go anywhere from 6 months all the way up to 12 months between injections. We're also looking at other mechanisms of action. So blockade of VEGF-C is being tested in phase 3. But we may have drugs in the future using a different mechanism of action than the drugs we've talked about to date. So it is an exciting time for us and our patients. And really, all of our goals should be the same, which is to have sustained disease control of our patients with these two blinding diseases.